Just one more minute, then we can start. All right, I think I'm going to start here. The numbers are still going up. We're 365 now, but I think it's good that we start. It is a good day for everyone. Ladies and gentlemen, welcome to this series of the Sada webinars. My name is Makhubele. I'm the CEO of the South African Dental Association. Today we have Prof van der Vyver, who's going to be presenting. And then we've got amongst us panelists that are already here. I'm going to start with the president of the South African Dental Association, that is Prof Moipolai. And then, thank you, Prof. I've got the chairperson of the board, Dr. Renir Pata, if you can wave. And I've got, thank you, I've got Dr. Lawrence Swart, who has been very instrumental on the development of or coordinating the development of the dental protocols. And of course, I've got Dr. Swanepoel, who is the chairperson of the Dental Practice Committee and a member of the board. Dr. Prof van der Vyver needs no introduction. I'm sure all of us know him by now. I'm gonna just ask Dr. Swart to introduce a guest speaker who may be joining us later. And then once he's done, I would like to then hand over, or I would like to just say something before I hand over to Prof. Dr. Swart, do you want to maybe tell us about the speaker that may join us sometime later?
Thank you, Casey. Egon Euwe is a well-known international implantologist. He's got a practice just outside of Milan, and he is an educational and practice manager also for education worldwide. And he was caught up in the COVID-19 pandemic. And I had many discussions with him, and he contributed. Hello, Egon. Dr. Egon Euwe has just joined us. Egon, we are so glad to see you. I was just starting to introduce you. He's got a private practice outside of Milan. He's very much involved in the academics in the University of Milan, as well as with Peet, where he does most of the international courses. He travels about half of the year. He travels around the world, educating people on the fine skills of a very skilled clinician. He's got a beautiful eye, and he can practically teach everybody what was happening. I was just telling them, Egon, how we spoke during these times and the experiences you had before lockdown. Casey, do you want Egon to straight away start, or how do you want to go with our evening?
I think he can wait a bit. We'll give him an opportunity just now. You will also see another face that's a guest today, Rani Naidoo. I'm going to ask Prof just to introduce Rani for us.
Good evening, everyone. My task is now to introduce Rani, and we've just spoke about her title, and it is very, very long. So I'm actually going to hand over to her to give you a title. All I know is that she's a key person at the 3M company. And the main task tonight is to answer and help me with questions concerning masks. Rani, can you just give them your title, please? Just unmute.
Good evening, everybody. Yes, my title is Application Engineer, Regulatory and Technical Manager for 3M's Personal Safety Division, which includes personal protective equipment such as respirators. Thank you.
Thank you so much, Rani. Thank you so much, Rani. Just before we delve into everything, I just want to make a few announcements before I ask the chairperson and the president to speak. Just to let you know, we have released a communication. The PPS PPE project has happened. By now, you would have received an email directly from PPS, and you would have received a communication directly from Sada. I have been contacted by a few dentists that already have received their PPE. So if you haven't received any of those, please make contact with us so we can give you that information so you can apply and receive your PPE. Secondly, there is a WhatsApp message that a particular member of the oral health profession is talking about something that they've learned from the Sada webinar platform. There is information that may not be accurate in that WhatsApp. I would like to make sure that people understand that it is not an official communication from Sada. I will be responding to that tomorrow. There will be a communication with regards to what we stand for in terms of what has been purported as coming from this webinar platform tomorrow. Today's platform, we have 2 CPD because we've realized most of the time that we don't get to finish our time and you guys still get 1 CPD. So we've applied for 2 CPD, which has been granted. And what I do want to say is unlike in the past, where we were struggling a bit, for those of you that are on the Facebook, and I see that it's very little today, there's only 3, which means it's not a big problem. But for those of you that are joining us via Facebook, if you want your CPD, you will need to go to our website, download this webinar questionnaire, answer that, and email it back to us. For those of you that were joining us via YouTube or Facebook previously and you have not written your test for the other webinars, all of those tests are now loaded. Going forward, the questionnaire will be loaded immediately. However, this may not be necessary because going forward, our Zoom webinar will now accommodate 1,000 members. So hopefully all of you are going to join here. And as I've been saying in the past, if you join via Zoom, you don't need to write the test. We will validate you after the Zoom a few days, and then you will be allocated your CPD points. Thank you so much. I would like to then ask the president first to say a few words. Prof. Moipolai.
Thank you, Casey, and welcome to all the panelists and our esteemed invited panelists, Ms. Naidoo and Dr. Egon Euwe. Did I say it right?
Yeah, that's correct. Thank you for having me.
I've been practicing like mad whilst Casey's talking, but hopefully we're in for an informative 2 hours on the clinical protocols that we have to adopt going forward. And once again, great gratitude to the Clinical Protocol Development Workstream that has been instrumental and fundamental in the development of these protocols. Thank you. I'll give it over to Dr. Pata.
Thank you, Prof. Thank you, Casey. I just want to say a few words. I've spent quite a bit of time over the last couple of weeks with dental practices that have followed our clinical guidelines and have done proper screening before they've actually seen patients. And subsequently to that, the patients have returned, or some patients have come back and have actually tested positive. In other words, they were actually asymptomatic patients that were treated. So I just want to say these clinical guidelines are so important, because even if you do all the screening properly, you will not know when you see an asymptomatic patient in your chair. And that's why these clinical guidelines, these clinical protocols are so important. Number one, to protect yourself, to protect your staff, but also to protect the public and your patients out there. So please adhere to these guidelines. It is so important because you might see asymptomatic patients. Please take care out there. Please stay safe. Thank you so much.
Thank you, Dr. Pata. If those 3 people that I'm seeing on Facebook are health practitioners, I would like to encourage you to use the link that has been provided to join Zoom directly so that we can have the information collected much easier. But if you're not health practitioners, it's okay that you can stay on Facebook. This is more to help you get your CPD easier, as well as to ask the question. But if you stay on there for whatever reason and you're a health practitioner, please, and for all the people that are on Zoom, please use the Q&A section to type your questions as we go along. Those questions are going to be answered later. We already have received questions around PPE anyway, and it's quite a long list. So if you have already sent questions earlier on, please do not send another question, because otherwise we're going to be here until tomorrow at 10 o'clock, and we don't want to be until 10 o'clock. We would like to go home and sleep. Our esteemed guest, Dr. Egon, if I can give you an opportunity just to address us, talk about your experience, and thank you again very much for working with us also in the protocol development work stream. Thank you. Over to you.
Yeah, thank you for this invitation. Proud to be on the team. Blackie asked me to express my experience just before the lockdown in Italy. And actually, the situation before the lockdown was that dentists sort of underestimated the danger of the virus. And that's within a week turned from underestimation into pure fear. I personally was in contact with an oral hygienist. She works in the Netherlands. As I'm Dutch, we are in close contact because we did some courses together. And she got the virus and she got really sick. She was sick for 1 month, short of breath, and she told me literally that she went through hell. And after she got a little bit better, it turned out that she had been treating as an oral hygienist 3 patients in the clinic in Holland where she works. And out of these 3 positive patients, 2 already died within that month of time. So that really shows that the situation for professionals in our field can become really, really dangerous. We're not playing with something that's that should be underestimated. And Blackie got all the points in the important points on in a file, and he develops a great protocol. So I think we should stick to that. The problem is, if we want to protect ourselves, we need certain materials. And in Italy, the situation after the lockdown developed in a way that it was very, very hard to find the materials and to get them in the office for when you start working again. So that's the next problem we will have to face also. So that's about, in a nutshell, the situation I personally experienced before the lockdown.
Thank you, Dr. Egon. Dr. Egon, if you have time, hopefully you can stay, because maybe your shared experience may be helpful when we come to the Q&A section.
Okay.
Thank you. Without further ado, I'm going to hand over to Prof. Peet van der Vyver to give the webinar for today, the presentation for today. Prof, over to you.
Can everyone see my screen?
Prof, we can. We can see your screen.
Okay, thank you, Casey. I've lost your communication, so I wasn't sure if I'm ready to go. So, good evening, colleagues, ladies and gentlemen. It is really an honor for me to spend some time with you tonight to speak about COVID-19. Firstly, I want to introduce the topic, safety protocols for your practice, COVID-19. Then as you met our panelists, Dr. Blackie Swart, Dr. Egon Euwe, and also Rani Naidoo from the 3M company. Now, allow me to start with this topic. I'm not going to just introduce PPE tonight. I'm going to talk about a lot of things. The first thing I want to talk about is viral shedding. And is there any evidence to support that pre-symptomatic and asymptomatic patients can infect us as healthcare workers? Now, this is a report from the CDC that looked at a lot of articles, and they came up with some evidence supporting this transmission of pre-symptomatic and asymptomatic patients. The study I want to focus on a little bit more is this one that was published in Nature Medicine, Temporal Dynamics in Viral Shedding and Transmissibility of COVID-19. Now, in a nutshell, what they looked at in this study, and there's a lot more, I'm just going to give you the crux of the study, is that they looked at the onset date of the primary case. They looked at who was infected and when was the onset of the secondary cases, and then also what was the exposure window for transmission between from the primary to the secondary case. Now I'm going to jump right to the conclusions of this study because this is what is important for us as OHC workers. The infectiousness of these patients started 2.3 days before symptom onset. And Renier has already elaborated towards that. So this is a very important point that I want to get across. 2.3 days before symptom onset, a patient can infect you or anyone in your practice. The most infectious time is regarded as about 0.7 days before the symptom onset. Most infectious time, 0.7 days before symptom onset. And then if we follow the curve as you become sicker and sicker, after about 7 days, you actually there's very little infectiousness from that specific person. So if we look at these graphs, we have to realize that 44% of infections or the infection potential occur in the pre-symptomatic phase. And that is very bad for us in a dental practice because that means we can't contain these people, we have to treat them, and they are very high risk for us in our practice. Let me give you an example. If a patient develops mild symptoms at day one, and they get tested and diagnosed with COVID-19, that means at that point that they tell you that they actually are COVID positive, they've probably infected most of the secondary cases already. Now, in this presentation, we're definitely going to focus on PPE, but I'm going to give you some literature research around the concept of why we have to protect ourselves, our staff, our receptionists, and also our sterilization people in our practice. So let's talk a little bit about surgical masks. I firstly want to mention this webinar from Dr. Marcus Trulsch. He's presented this webinar worldwide. He was also on digital dentistry in South Africa, and this created a lot of confusion for us. He currently states that you can go into your practice, work with a surgical mask and eye protection. And he's got good research to back this, and I'm going to share with you some of these studies. Most of the studies use the influenza virus as a control. As you can see on my slide, the influenza virus and the coronavirus is very similar in size, 0.06 to 0.014 microns for corona and 0.08 to 0.12 microns for influenza. So there are quite a few studies that we can bring up out of the literature that show us that when we talk about the influenza, there's not a big difference if we use a surgical mask or an N95 mask. Here's another study. I'm not going to go through all of them in detail, And then I'll highlight a few more. There's a very popular Toronto study that shows there's no significant difference also for influenza between N95 and a surgical mask. There's even a meta-analysis where they looked at 8,500 patients. And I also confirmed that there's not a big difference between an N95 and a surgical mask. Then there's a literature review on MERS-CoV that said if it's only droplet spread at that stage, they will recommend a surgical mask. But they also write in the paper that if there's some concern of aerosolization of the virus, then maybe it's better if you wear an N95 mask. And then if you go on the internet, you can find all these reports. Here's a study from Smart Air Filters that show if you looking at infection rates, if you wear no mask, you have a 17% chance of getting influenza. If you wear a surgical mask, 5%, and if you wear an N95 mask, 4%. So I think this leaves us as dental practitioners very, very confused. Now, I always teach my MSc students that if you want to prove something, you either prove it via statistics or you go and find one or two other articles that prove the opposite. And I can find quite a few, and I'm not going to highlight them, but I want to just focus on this article for a moment. This is published in Health and Safety Executive, and I want to read with you the main findings of this article. The study focuses on effectiveness of surgical masks against a range of airborne particles. They use separate measures and levels to inert particles, and in this study, they use live aerosolized influenza virus. And the findings was that surgical masks provide 6-fold reduction in the exposure. Live viruses, and this is very important, live viruses could be detected in the air behind the surgical mask tested, and that's not good news for us. And by contrast, a properly fitted respirator, like an N95, provided in this study 100-fold reduction. So there is good evidence to show us that there is benefit of wearing good masks in the current pandemic. Now, if we're going to advocate to dentists to use surgical masks, I think we have to tell them what level of mask. And this is not told in these webinars that people are told to wear surgical masks and eye protection. You have to know what the ASTM level is of the mask. You need to know what the BFE, the bacterial filtration efficiency. You need to know the PFE, very important, the particle filtration efficiency, and not a lot of masks list on the boxes viral filtration efficiency. And then you also want to know about the fluid resistance, depending on what procedure you do, and the delta P will tell you how breathable the mask is. Now, I want to urge you tomorrow to go back to your practice and look at your box of masks and see if you can find these details. I had the embarrassing experience this week to actually find probably about 10 boxes of masks in my practice, and most of them don't have any of this information available to me. The only product that I could find, in fact, was the 3M box of normal surgical masks that is rated very high as an ASTM level 3. Now, I'm gonna, my last slide on this topic of Marcus Trulsch. Blackie pointed out that in his webinar, he points at number 6 in his summary. He states the following: N95 and a disposable gown must be added to COVID-19 or SARS-CoV-2 positive patients. Now, I think if you looked at my first few slides where I showed you that 44% of infections occur in the pre-symptomatic phase, I think you have to realize tonight that you have to accept that we have to have better protection than the surgical mask when we see these patients if we don't know, and we have to accept that they actually are potentially COVID positive. Now, who do we go to when we're confused? We go to these websites. We go to CDC, we go to NIOSH, we go to the WHO, NHI, the FDA. And let me take you through what the CDC says on their website. This was in the beginning of the pandemic. And they said, put on a respirator or a face mask if a respirator is not available before you enter the room. And then they said, secondly, N95 respirators should be used instead of face masks if we are doing aerosol generating procedures. Now, let me show you one more study on masks. This is a study that was published in the Journal of Royal Society of Interfaces. and they looked at the effectiveness of face masks to reduce the hazards of airborne infection among the population. Now, very quickly, I'm going to give you the outline of this study. It's a very simple study. It's an in vitro study. What they basically did is they put on mannequins, they put surgical face masks. They call it the face mask here, but it was surgical masks. And they taped the mask closed with insulation tape or some tape that they've used. So the mask is completely sealed. The second group, they left the top 4 millimeters above the eyes, they left open so that something can penetrate in there. The third group, they left the top part of the mask open, but they still kept the 3 other sides sealed with tape. And then the fourth group was how a healthcare professional will just wear a mask, just putting it on and go into the room and treat the patient. Now you can clearly see on this slide that the first 2 groups gave very good protection, but the one that was open on top and the one that was used in a normal wearing fashion did not give us very good protection. Now, let's look a little bit more closer at masks. If we look at face masks, not surgical masks, just face masks, you can see that the criteria there is that it has to filter 3 microns above 95% filtering potential. If we look at a surgical mask, it's still 3 microns, but then they include that it should filter about 0.1 microns, about 30% of those particles as well. And that's in the range where we're talking about the coronavirus. And then if we look at N95 masks, we're looking at 0.3, not 3.0, but 0.3 microns. And some of the good masks goes up from 95% to 99.7 of the filtering potential, like a FFP3 mask. Now, let's just stand for a moment here and talk quickly about why is this important. The reason why the manufacturers look at 0.3 microns is because it's the most penetrating particle size that can go through a mask. Particles above 0.3 move in anticipated ways, and they get trapped in the filter gaps smaller than the particle size. So they're easy to capture, but the 0.3 is the most anticipated particle that you have to catch. Particles smaller than 0.3, you might think, oh, but they just go right through the filter potential. They have a phenomenon called Brownian motion. Now, let me explain to you in a moment what this motion is. I apologize, I put this writing on and I forgot to take it off. But basically what it means is that small particles they're too small to just go and filter or move on their own. So they have an erratic type of movement, and they combine and they get close to nitrogen and oxygen molecules. And then they play like a pinball effect. You can see in the drawing on the top right. They jump between these particles and they have a pinball effect. And they are actually then easier filtered than the 0.3 micron particles. That is the most penetrating particle that we have to look out for. Now, let me summarize this by just telling you what you should be looking for in your practice. If you're going to use a surgical mask, as you know, this is probably for the essential minimum standard if you're going to do a non-aerosol procedure. So here's the levels: ASTM 1, ASTM 2, and ASTM level 3. So I would suggest in this pandemic that you're actually using at all times ASTM level 3 type of mask. Now, this is the American standard. Some of the boxes might not have that on. So then you have to look for the rest. Look at the BFE, if it's above 98. Look at the particle filtration, if it's about 98 as well. And then the breathability doesn't matter for when we talk about the coronavirus. That's just for comfort for the operator. But make sure that you're in ASTM level 3 criteria for the mask, surgical mask that you're going to use in your practice. I want to highlight this study that I found. You can see the reference at the bottom, Journal of Research Society Interface 2012. Here they've looked at if you have a surgical mask or different masks on, like a homemade mask, a surgical mask, or a FFP2, a N95 mask, and there's particles in the environment, 33% of the particles can go through a homemade mask. 25% particles can penetrate through a surgical mask. And if it's a good quality N95 mask, only 1% of the particles will penetrate through that. But now look at the interesting thing. If the operator, for instance, cough and he wears one of those masks, if it's a homemade mask, 90% of the particles will be exhaled. If it's a surgical mask, 50% of the particles will go through. And if it's a FFP2 N95 mask, they could still go through the mask 30% through that quality mask. And there's also air escape on the sides. Despite the fact that we do tests to fit these masks properly, we have to accept that when we exhale, even with an N95 mask, there's some of the exhale that escapes through an N95 mask to the outside as well. So we have to take that into account, and we're going to talk a little bit later about that in more detail when we talk about half-face respirators. Now, let me share with you this shadow graph of human exhaled airflows when someone wears a surgical mask and they cough. You can clearly see there's quite a lot of exhale. And here I'm going to show you it with a surgical mask when someone sneezes. And look at the shadow graph. There's quite a lot of plume around this person's face. I'll show you some more as we progress. Now I want to summarize just the masks again. ASTM level 1 has got a very low barrier level, and you should be using those only for examinations and taking impressions and maybe restoring implants. ASTM level 2 has got a moderate barrier level. You can use it for prophylaxis, endo, sealants, and resto procedures. But in this pandemic, and where we are with aerosol generating procedures, as I said before, I would recommend that you use an ASTM level 3 mask that's got a high barrier level, especially if we're doing ultrasonic scaling, air polishing, crown preps, or complex oral surgery. And if you look at the literature, they even suggest that if you do a high aerosol procedure, that you should change your normal surgical mask every 20 minutes. Now, recently, the Private Practitioner Council released a document in London, and they brought up a very interesting concept. We are all talking about aerosol generating procedures, and they put in the document that they just released another concept that I want to focus your attention on for tonight. AGE, aerosol generating exposure. So you could have aerosol generating exposure in your practice or in your surgery without doing an aerosol generating procedure. And you have to take that into account, because maybe the aerosol generating exposure is high and you're doing an examination, and that might put you in a category that you might have to wear an N95 mask for that category. So let me give you examples. If there's aerosols in your surgery, someone may be coughing, maybe a parent comes to the practice and they're coughing. I showed you the plume that goes through a surgical mask or a homemade mask already. Coughing, sneezing, talking, laughing. A positive patient that's maybe in your practice. The type of procedure, the level of aerosol you're going to create, the length of time. The longer we work on a patient, the higher the aerosol generating exposure becomes. And also, are you using mitigation factors like high volume suction? Do you have a rubber dam on, or extra oral suction that I will elaborate a little bit more on right at the end of the presentation? So let's summarize the first part of this presentation, the take-home messages. The first message, 44% of infections or infectiousness occur in a pre-symptomatic phase, and we have to be aware of that. Can we use a surgical mask for SARS-CoV-2? We don't know. There's not good evidence on it. And the Sada protocol and this webinar do not recommend that you use that for aerosol generating procedures. I want to repeat that. I'm going to show a few cases maybe where we just use surgical mask, but that is not part of the protocol. If you're going to use a surgical mask, make sure it is a good quality ASTM level 3 and cover it at least with a visor. That's the least you can do in your practice if you really can't afford expensive PPE and you really want to protect you and your staff. I want to repeat this. This is not part of the protocol document, but that's the minimum. Not just a surgical mask as suggested by Marcus Trulsch. A good level surgical mask and a visor covering it. And also ensure from the study I showed you that the mask is properly placed, that it covers your nose tightly, that it's tied back properly, and that it covers past your chin to create maximum protection. And then lastly, I think from what I've shown you so far, respirators or N95 or FFP2 masks are probably recommended for where we are with this pandemic. Please keep in mind that we are approaching high levels. We are approaching the peak in South Africa. Most countries where we see people speaking has passed the peak. And it's very easy to then say, yeah, you can just work with a surgical mask. Don't worry, it's not a big problem. I want to urge you to think about that tonight. Now, let's move on and talk a little bit about transmission of this virus. And I think most of us will agree that the biggest form of transmission is droplet form. But I want to focus a little bit on aerosol transmission and look at the current data available on that. If it's aerosol driven, we have a serious problem in dentistry. If the aerosol we're creating contains the virus, we have an even bigger problem. I think most of the evidence are showing that it's probably not as high as we think, but the key point is we do not know at this stage. There's not good studies to contradict that. This is a study or a paper by Harrell and Molinari that was written in 2004 and showed us the potential and danger of aerosols in our practice for contaminating us with bacteria and viruses. And it's a very well-referenced paper. I'm not going to go in detail into that, but you also know that these two gentlemen in Canada has recently written a paper to decode all these papers and say that it is nonsense. It's not such a serious issue. We can carry on with dentistry and we can probably carry on with the minimum amount of PPE. Again, I want to say it is not proven at this stage. So be careful to listen to these types of comments. So what is SARS-CoV-2? Is it droplet transmission or is it aerosol? Now, before we get to that answer, let's talk a little bit about these two concepts. So let's classify the transmission according to the behavior of the particles in the environment. If a patient coughs, for instance, he will emit droplets that's about 20 microns in size if he coughs, sneeze, shout, and these droplets will succumb to gravity and they will fall down on the ground about 1 to 2 meters away from the patient. That's the first way of transmission. The second way is aerosols. They are fine particles, about less than 10 microns in diameter, and they can travel much further, and eventually they will also land on the surface, on the floor. These figures differ from article to article and different opinions. I'm just using this as a base to get the concept across. So if you read an article and droplets are 50 microns, don't worry about it at this stage. Then the aerosols will be 20 maybe. I'm just using these figures to get the concept across. So aerosols is about less than 10 and droplets probably more than 20. And then there's also particles in between 10 to 20 that we will discuss later on. Now, if we look at particles smaller, if we can go to a more granular distinction between the aerosol particles, if there's particles less than 5 microns, they can travel all the way down to the alveolar space. And these are the particles that actually cause pneumonia in the patient's lungs. If the particles are smaller than 10 but larger than 5, people reckon that they sit below the glottis and they will just infect or go into the tracheal branch up to that level. The problem we have with droplets is that they fall on surfaces, they fall on the floor, and if an uninfected individual touches it and touches their face, there's a chance of inoculation. And that is why hand washing is so important in our practices and at home and everywhere where we go. Now, there's also droplet nuclei. Those are particles smaller than 10 microns. So this is when the water component of a droplet dries up a little bit, maybe because of wind or temperature conditions. The remaining virus then, if it evaporates, the remaining virus then floats a little bit longer in the air, and they can behave very similar to aerosol particles if there's evaporation of some of that liquid of the droplet. And then depending on wind conditions, for instance, in your practice or ventilation, droplets might even travel further than 2 meters. Let me give you an example. When you go to the sea on a windy day, and you sit outside, you sometimes feel the spray of the sea on your face. And there you've just experienced droplets that became airborne. And it happens very quickly. And what does it mean for us for influenza or SARS-CoV-2? It means that we can create those situations in our practice, and we have to take those instances into account, because doors are opening, people are moving in hospitals, beds are moving, people are walking forwards and backwards through your surgery, and there's constant movement, and that can allow these droplet nuclei to actually be slightly more airborne than a normal situation where it will just drop down to the floor. So if we think that there's aerosol or airborne transmission possible, we have to use good masks. The droplets that falls on the surfaces, we call fomites, and there we have to practice good hygiene, as I mentioned before, hand hygiene, and also create social distancing to prevent transmission and inoculation. So I'm coming back to the question, is it airborne or is it droplet transmission? I think the answer is probably both, like influenza. Now, let me show a few more studies with you. This is quite an interesting study, aerodynamic characteristics of RNA concentration of SARS-CoV-2 aerosol in Wuhan hospitals during the outbreak. Now, there was 3 places they investigated: the Remnant Hospital in Wuhan, some public places that I'm not going to discuss because it's going to make the discussion too long, and Wushang Fanshang Field Hospital that they looked at. And they looked at aerosol and surface samples, and there was a lot of positive patients in these 2 hospitals. Important to note that they only looked at the viral RNA that was present in these rooms or situations. They didn't check if this remnants of RNA can infect someone. I'll come to a study like that after this one, but I want to highlight this study because it gives us very good information for our practices. Now, this is the areas they looked at, and if you look at work zone A, B, and C, there was about 200 positive COVID-19 patients in that ward. And you can see that there wasn't a lot of RNA visible on the surfaces, and also in the airborne situation in those wards. And also, if you look at the intensive care unit number 5 and coronary unit and ward zone 16, there was about nothing that they could detect on RNA viruses. And they reckon this was due to good ventilation that was very effective, and some of the intensive care units was negative pressure rooms. Now, in 2 of the intensive care units, they then did floor samples, and they spot a very high sample load of RNA on the floors. You can see the one was 31 and the other one was 113, a very high concentration of remnants of RNA. And that is key for our practice, because we have to realize when patients cough or they go to your bathroom, for instance, they might cough there, or patients speak to you when they take their mask off. If they transmit droplets, it's going to be on the floor. And that's how we're going to start transmitting it into our practice. Another important thing from the study was that they found a lot of RNA inside the mobile toilet room. And that's critical because patients go to the toilet, they could take their masks off, they can breathe. We know that they find the virus in feces and urine, but very high levels was actually detected there as well. And a critical point here is to disinfect your bathrooms on a regular basis. I don't want to go so far to tell you this, but I probably think that if we look at floor transmission, fomites that's on the floor and probably your bathrooms is probably a high risk area if we can prove that our dental aerosol is not infected, as we probably suspect. Another alarming conclusion from this study was that there was a very high airborne concentration of RNA in the changing rooms, where people removed their protective gear. Now, that's critical for our practice. Where do we remove the protective gear? So we could be contaminated with the with the virus or the RNA presence of that. And then when we take our protective gear off, you can see we spread it in that area or in that room. That's what their conclusion was in the study. The second conclusion they made is maybe the healthcare professionals brought it in via their feet and their protective covers into that room where they found a high load of virus RNA. So let me summarize the presentation again up to this stage. Sorry, I apologize. I've got one more slide. This just summarizes the study. So ICU isolating rooms was very low in RNA. Staff rooms, patient toilets, and staff change rooms was very high. And I want you to think about this tonight and apply that principle to your practice in future. Now I want to acknowledge Franz Wiesbauer for his webinar, because I got a lot of the drawings from the aerosols that I showed you from his webinar, and I'd like to acknowledge him for using some of those. I made my own drawings, but the concept was brought across by him. So the take-home message up to now is there's no evidence to prove that dental aerosols is not infective, just as much as there's no proof to prove that it is infective. So we have to assume at this stage that we have to protect ourselves and our staff against it, and then until there's conclusive evidence. Secondly, our patient toilets or our toilets in our practice is a concern. We have to disinfect them regularly. In my practice, for instance, we incorporated a UV light that we leave on 24/7, and we lock the door. And when a patient wants to go to the toilet, we then put the light off and we unlock the door because it's damaging to eyes and skin. They can't go in there. But as a control measure, we lock the door and we keep at least 15 minutes between patients or staff that use the toilet before someone can enter again. That's besides the normal disinfection route. You can also do UV light disinfection, as we discussed with Johnny and in a webinar. The next point, room where you doff and don your PPE is a concern. Think about that. So I think another concept that we have to take into account and ask a question is, so how long will the virus particles survive if they are maybe airborne or if they become fomites on a surface? And the biggest question is, if there's remnants of RNA, will they be able to infect humans? That's the question we should ask. That's the concern, because maybe we see remnants of RNA on the surface, but we're not sure if it can infect humans. So let me share with you a few more studies very quickly. This is published in the New England Journal, Aerosol and Surface Stability of SARS-CoV-2 compared to SARS-CoV-1. What did they find? And I'm going to cut to the conclusions. I'm not going to discuss this study in detail. They found that the virus can survive SARS-CoV-2 now for more about 48 to 72 hours on plastic. And that's not good news for our practice, because a lot of our surfaces is plastic in our dental surgery. The second surface is stainless steel, and that's also a concern because lots of our equipment is stainless steel, and that is 24 hours that it stays active there. Cardboard, probably equivalent to a mask material, is about 24 hours, and copper is about 8 hours. But interesting enough, in this study, they looked at the aerosols as well, and SARS-CoV-2 was present at high titers for up to 3 hours. And this is bad news for the industry. Even if it's not our aerosol that we produce, that might be a patient that's positive that coughs in your practice, or a parent that brings a kid in that maybe sits and coughs in your surgery in a confined space. So if it is airborne, should we take precautions? Let's see what the literature say about that. This is a study in the Journal of Infectious Diseases. They looked at airborne or droplet precautions for healthcare workers treating coronavirus patients. They did a systematic review that's very high evidence. They took 393 papers that was published. As you know, lots of papers was published very quickly in this short period of time, but they only selected 10 papers to draw a conclusion from. And I'm going to just read to you the conclusion. Available studies show that SARS-CoV-2 can be detected in the air and remain viable for 3 hours after aerosolization. The weight combined evidence supports airborne precautions for the occupational health and safety of the healthcare workers treatment patients with COVID-19. Now, let's just stay back for a moment and think about this. So remember, we discussed its droplet transmission and a possible airborne route. So we would expect that most of the virus that is shedded is in droplets. But I want to focus your attention to this very, very significant study from Donald Milton's group. And they looked at infectious virus in exhaled breath of symptomatic seasonal influenza cases from a college community. Now, very quickly, what they did is they collected the exhaled breath from patients that is positive for influenza. This cone drew 130 liters per minute volume through, and then they checked if the patient breathes, coughs, or sneezes naturally. They also asked the patient to recite the alphabet at 5, 15 minutes, and 25 minutes, and they checked what happened and when the patients coughed. So this machine collected two types of particles: coarse particles above 5 microns and fine particles less than 5 microns. Now, interestingly, the coarse particles, if the patients didn't cough, there was no infectious RNA influenza virus. If they coughed less than once in that period, there was a tiny bit of RNA collected. If they coughed more than once in that period, there was more virus. But there's not a big difference between if they coughed a little bit or coughed a lot. And you can see with no coughing, there was nothing. Now, interesting, the fine aerosol that we create in dentistry as well, that we think maybe is less infectious, they showed RNA particles for a group of patients that never coughed when they collected fine particles. And you can see a drastic increase in the RNA particles for patients that cough less than once or more than once. So what does this mean? It means that people produce fine aerosol particles with a high viral load, even at times when they don't cough. And just think about that, because lots of times we sit and have long conversations with our patients in our chair. I want to show you this shadow graph of human exhaled airflows of two people having a conversation. This is from the National University Hospital in, I think, Taiwan. And look at the plume of each person, how it moves towards the other person and how it mixes up. And this is why social distancing is so important for the transmission of these viruses. Look at the exhaled plume, and if you follow it very carefully, you can see that they actually mix up and the one plume goes to the opposite person. So these fine particles mix up with the other plume, and this is exactly what facial masks or surgical masks are not made for, is to protect you against these type of particles. I want to end off with these studies with two very quick examples. This was a choir practice that people are quoting a lot in their studies in Skagit Country in Washington. There was one infected person in the choir, and there was 61 persons in the choir. They had a 2.5-hour practice. 33 of them were confirmed infected from this one person, 33 people, and 20 probable cases. 3 was hospitalized and 2 died. And in total, 87% of this choir had some consequences of this one infected person. So in the study, they say most of the transmission was properly droplet and fomite transmission, but they also think there was an airborne component because of singing, and they think this person was a super emitter at the highest level of infectiousness when this happened. And the second study I want to highlight is the one of the restaurant in Guangzhou in China. Very quickly, on the 3rd floor, there was, I think, 140 people seated, and we focus you to this room where there was 5 tables. The infected person sat at table A1. You can see the yellow dot there. A1 was the infected person. And I also want to draw your attention to the air conditioner on the right. So the air conditioner blew from the right-hand side to the left-hand side of the room and then filtered back to the intake of the air conditioner again. Now look at table B. 3 people got infected there. and 2 people on table C, and not all the people at table A, because the air conditioner probably moved the droplets further away from those people because of the direction of the airflow, and those droplets probably became droplet nuclei, and they probably had the potential to become aerosolized and infect these people. And this happened on the 24th of January, and you can see the dates when the other people were infected. Now, let me show you this table is highlighted in the study. This is just recommendations from the WHO, what you should do in low and high risk situations in your practice. Low risk, they recommend masks, a good mask, and then a respirator for high risk areas like AGP. The CDC, mask and respirator, and the ECDC, European Disease Control, even goes so far to say maybe even a respirator for low risk procedures and a respirator for high risk procedures. So let's summarize again and give you some take home messages. We should consider taking airborne precautions from the studies I've shown you. We can't ignore them. We have to protect ourselves properly in our practice, especially when we interact with patients and examine them. Don't think that that's just a low risk procedure. That's probably where we're going to get infected. Even if there's no AGP procedure, remember of the AGE, the aerosol generating exposure in the whole room, whatever might be present there. Now, allow me to just show you a few examples of a webinar that came from Wuhan University. The first question lots of you ask is, how many people are a nurse and assistant in the oral healthcare facility? But one dentist got infected, Dr. L, and he was 40-year-old male. He died, and his sister was his assistant, and she was also got COVID-19, but she recovered. And then there was 2 other dental nurses that got infected, even with this strict precautions that I've just shown you. And they reckon one was infected in a hospital and one was infected in a private function. Also interesting in this webinar is to show you, this was right in the beginning, which healthcare professionals died. And interesting enough, they talk about the ophthalmologists that often approach the patients without normal surgical masks. And in fact, 3 of them died in this specific study they highlighted. Now, allow me to just summarize what protective gear they are wearing and did wear during the outbreak in Wuhan. I won't go through the whole table. I'm just going to show you the ones that's highlighted in blue. For oral examination and low-risk procedures, they had hand hygiene, surgical mask, goggles, gloves, work clothes, and a cap and shoe covers they regarded as optional. Our protocol specifies that you should have actually shoe covers even for a low-risk procedure during the day when you work in your practice. But look at this one. This is exactly in accordance with our Sada protocol. Aerosol generating procedures, hand hygiene, a N95 mask, face shield, goggles, gloves, work clothes, optional isolation gown, optional protective clothing, a cap and shoe covers. And then if it's a suspected positive patient, you can see that we add then probably an isolation gown as well. So allow me to show you just a few things that you have to consider. These are some more shadow graphs showing you the plume when the patient do things in your practice. I've turned these videos upside down because I want to show you when you sit in your practice and chatting to a patient and talking to him and asking him what's wrong and the masks is not on, this is how the plume dissipates around the patient. So this is a patient that's just breathing normally, probably more heavier because they're all scared in our practices. Can you now see why it's important to have protective gear on? Why it's important to probably have a disposable gown on? If we consider that there might be in these fine there might be virus in these fine aerosol particles, according to the study that I showed you from Milton et al. Look what happens when the patient mouth breathes. Even more plume. And then don't tell jokes in your practice anymore. This is quite serious because look what happens when the patient laughs. A very high velocity of plume when the patient laughs in your practice. And coughing, that happens very easily. The patient just coughs and they cough directly onto you and your dental assistant. So let's get to the last part of the presentation, and let's talk a little bit about respirators, because that's where I was moving, talking about having good protection with an N95 mask. Now I want to highlight this mask, and Ronnie can probably talk a little bit more about this. I'm going to highlight this mask, and I apologize for promptly tell you where you can buy it, because I know you're all battling, and we're going to try and minimize questions later on. This is a 3M mask, and I'm going to also ask Ronnie to talk later on about the electrostatic potential of the 3M mask in the filtering potential of virus particles. And I'm not sure which companies have that technology, but most of the 3M masks have them. I'm not sure if it's in this mask, but this mask is not fluid resistant, but it's still a FFP2 mask. It's a very good mask. If you can get hold of this mask, they come in at a very good price. For instance, Access Dental is selling this mask for about 18 Rand a mask in this current time. So if you can get hold of this, it's an excellent mask. I would probably suggest that with an aerosol generating procedure, you cover it with a facial shield for a little bit extra protection if you're going to create a lot of plume. Now, I want to start with this. There's a lot of fake respirators on the market at this stage in South Africa. Now, Casey has already elaborated to this, that the mask that is distributed by PPS is properly registered by, I forgot the company's name now, but it's properly registered and it's not fake masks that you will receive. But what I want to highlight here, if you look at the CDC website, they give you signs that the respirator may be counterfeit. Please note, not counterfeit, may be. And it could be a lot of these things. And one of the things that's creating havoc now is the fact that when you see an N95 mask with ear loops, people think it's fake. It's not fake. It is approved N95 mask. However, we have to question a little bit how tight the seal would be, because that's why there's 2 rubber bands going around N95s to cap it properly around your face. So depending on the quality and where it comes from, you might find that there's more exhale air coming out of these masks. But be careful before you label it as completely fake. Now, very quickly, I'm going to take you through this table, and that will summarize to you what you have to use in your practice. We've already talked a lot about surgical masks. I'm going to put it into this classification again. Then we talk about respirators, N95s, FFP2s. We'll go through a table in a moment. Then we can have half-face masks that we've highlighted a lot on this webinar as well. They're more cost-effective. They give, in my opinion, they give you a little bit better protection. For me, it's easier to work with them for a 2-hour procedure. The breathability is amazing. And then you can also go one step up, power air purifying respirators. For instance, the one I'll highlight is from the Clean Space company. Although it's a nice to have, but I would probably say if I look at this table tonight, if I have to just choose one mask, I will probably go for a half-face mask to be most comfortable for long periods in my practice. So let's run through this table. Let's look at the fit. A facial mask, surgical mask is loose fitting. Virus particles can penetrate from the sides. An N95 is tight fitting. Half-face mask is very tight fitting, and also the PAPRs. In fact, what I love about those masks, especially the half-face mask from 3M, you can actually feel how it sticks to your face, and you know there's a good seal. Fit testing is required with most of them. Ronnie can maybe talk about that as well, but with a surgical mask, no fit testing. Important point that I've mentioned before, a surgical mask is actually there to protect the operator of the patient from the operator. That's actually what a mask is there for, surgical mask, not to protect the operator from the patient. But if we get to a ASMT3 level, there is probably protection for both. But if you look at a respirator, there's 2-way protection. The half-face mask and the PAPRs, there's 2-way protection. But we have to consider that there's an exhale valve, and a small amount of the exhale will go through that valve. So there's ways to combat that. You can close the valve with a surgical mask in front of it. I'll show you some examples. Or you can actually place an N95, a piece of N95 mask there. But in general, it's not a concern because these masks are used in the medical operating theaters a lot, especially the one I'm highlighting on the right-hand side. The Halo one is extensively used at this stage in positive COVID-19 wards. And then designed for reuse, surgical masks, not really. If you look at respirators, we are reusing them because they're not available. But ideally, they're not actually there for reuse. And the other two is for reuse. And then you can see breathing, lastly, very easy, very difficult, easy. And the PAPRs are breath responsive airflow. So as you breathe, you will inhale some of the air. Now, let's just clear confusion very quickly and talk about the different grades of masks. N95 is a USA marking. FFP is a European marking. KN is a China marking. P2 is Australia, New Zealand marking. And DS2 is a Japan marking. So very quickly, a FFP1 or a filter that's P1, filters at least 80%. FFP2 and a P2 filter at least 94, and an N95, KN95, and DS2 at least 95%. So you can see they're very close, those last two together. And then an N99 is equivalent to a FFP3. They filter at least 99%. A P3 filter that you put on the side of the mask will filter 99.95, and an N100 will filter 99.97. So FFP2, P2, N95, KN95, these two is probably in the same range of filtering potential, where N99, N100, the P3 and the FFP3 is more or less in the same filtering potential. Now here's the clean space mask. It's a very comfortable mask. It's very expensive. It's got a positive flow pressure valve, so a little bit less exhale go out. I find it an excellent mask to work with, but with my microscope, it sometimes interferes when I look through the binoculars. But let's get to the last part of my presentation, and this is what we actually wanted to talk about. But I think I've built a good foundation for you to realize why these things are important. I didn't just want to show you this is the essential minimum, because then you walk away and you think, ah, yeah, well, this is nonsense. There's no virus in our aerosol. We don't have to worry because my patients are not testing positive. You have to be very careful, and I'm going to go through this very quickly. On the bottom of my slide, you also see AGE, aerosol generating exposure, that I want you to keep in the back of your mind. It's not just about the procedure you're doing. How many people is in your surgery? Did they cough? Did you maybe see a positive patient before this patient? Did you allow enough ventilation? Because that can push up the aerosol generating exposure in that room. So we start off when we look at the essential minimum requirements that you're going to do for non-aerosol procedures. And here you can see we need a head cap. We need some goggles. We can use a surgical mask, but it must be a high level of surgical mask. You can probably do this procedure with your normal clothing that you wear to work. If you have open arms, you have to wash your arms. The same as hand hygiene, arm hygiene, disposable gloves, and some foot covers. That's what we're going to do for the initial essential minimum for non-aerosol procedures. And goggles is very important here to protect your eyes. And also if you touch somewhere and that you don't touch in your eyes. And there's lots of different goggles on the market. I'm not going to go through them in detail. Now we're talking about the essential minimum for aerosol generating procedures. And here I'm going to show you two examples. Our document says maybe a N95 mask, goggles, a visor, a head cap, more protective clothing. And when we do aerosols, you can think, well, from the studies I've shown you, it's quite important to dispose of that clothing, or washable gowns, not just the clothes that you sit the whole day in your practice with and you've been exposed to aerosols. Surgical gloves or normal gloves, sterile gloves, and shoe covers. So here's two options that Misty in my practice dressed with today. You can see that she's got protective glasses on, she's got an N95 mask on, and she's got a disposable gown. And now I'm going to highlight this, unfortunately, again, because one of the key things that's asked is where can we find an affordable disposable gown? We've looked everywhere, and if we have non-woven type of material, you're paying at this stage, the cheapest probably from 75 to 180 Rand for a disposable gown. And I must agree with you, we cannot afford that with the amount of money that we spend on PPE. So this gown has just come in from Access Dental, and they're going to sell this gown for 9.50 Rand. And I think that can become a disposable item. It's a very comfortable gown. It's got full arm sleeves, and you can dispose of that. So in total, I just want to see the price. It's about 475 Rand for a box of 50. So I think to answer you, the questions that we're going to have afterwards, this is a affordable option. And then you can see the second instance, she's dressed in addition with a surgical visor for this aerosol generating procedure. You don't have to, but it also protects a mask. So she can probably wear a mask for a longer period of time, and there's less aerosol and virus contamination on the mask. I just want to highlight this slide. If you're going to wear a visor and you do an aerosol generating procedure, I think it's a good idea to have a closed visor and not open at the top, because if the aerosol goes to the top, and remember we've showed studies when we talked about rubber dam, that when you have rubber dam isolation and you work in an aerosol generating procedure, most of the aerosol will go to the operator's head, and that aerosol will just drop into on top of the patient's, the operator's eyes again. So I prefer to have a closed visor. Let me show you a few small short video clips of how we work in the practice. Here you can see I'm working according to not to the protocol. I'm working with a surgical mask, AST 3 level, and eye protection and a visor. So again, I want to stress that this is not according to the protocol, but that is probably the minimum requirement if you cannot afford any PPE in your practice. Yeah, I've moved up a level. You can see I've got an N95. I've got protective glasses over my glasses, and I've got a visor as well. Yeah, I'm using my loops. Now, I find it very difficult when we bring in loops and microscopes into the equation to wear protective gear properly for our eyes. I'll show you a photo now what Blackie is doing. I see someone has asked the question that evening, but no one answered it. So let me answer the question here. If you have through the lens loops, you are in trouble like I am, because you can't really protect your eyes unless you can find very flat protective glasses with your lenses in. You can't put protective glasses over your current spectacles and then wear the loops. You can't see. You see 50% of the field of view. So I'm busy currently investing in a very flat pair of protective glasses where I can incorporate my prescription inside. At this stage, I am open on my eyes and I'm using a visor to protect myself. If you have flip-up loops like Blackie has, or loops that's slightly further away, you can get away by using protective glasses and then your loops, and you'll see Blackie even covers it with a facial shield as well. So here you can see a procedure where I'm using my loops. I've got my airspace mask on, and here you can see Blackie with his protective glasses, his loops that is a little bit further away, and he's also got a visor on. Now, as you know, and you'll hear from Ronnie tonight as well, is that the 3M masks are nearly sold out. And the second problem we don't have to correct filters for them, the protected filters. So there's only open filters available. You can use them, but you have to protect them with something, or you have to dispose them after each patient. And if you can protect them probably with a mask, then you probably have to dispose them every day. The protective filters, the 6038 and 6035 and a 903, I can't remember the numbers there, you can probably wear for a month because they are protected. You can just wipe them off, and Ronnie will talk about disinfection of these masks later on if there's a question on that. I want to focus your attention to this mask that Blackie found in Cape Town from a company called PSA, and this is what he's currently using on that slide to operate with. It's a cheaper mask than the 3M one, and you can put P2 or P3 filters on there. And the problem here is that they open on the sides, so aerosol can go in there. So you can protect that with a surgical mask, but it's too short. And if you're worried about the exhale, you can cover it with a piece of surgical or N95 mask. And you can see here, Blackie has customized a little cap for his mask. But in all fairness, I think if the operator is far from COVID positive and you are sure, the amount of exhale that goes out there is very, very a very small amount. So here's the ideal for me, a 3M half face mask. And here you can see my Janice Linda working with her loops, again, pop-up loops there. And that is the capsulated filters that you ideally want. There's the exhale valve that to show you. I'm not going to hide it away. It might be a problem, but please remember that even with a N95 mask, there's still exhale going out. So we're not more protected in those situations. In fact, today I checked with all these masks. I find that I exhale a lot less with these type of respirators compared to an N95. When the N95 is tight around your face and you're getting hot, you start breathing a little bit more. I think you're actually exhaling more on the sides of those masks compared to these respirators. Now I want to show you another mask that Blackie also found from the same company that's even cheaper. The previous mask is about 400 Rand plus filters. This mask is 150 Rand plus a filter. I think the filter is 90 Rand. Initially when I looked at it, I thought, yo, this mask looks very cheap because the photo on the website looked terrible. But I like this mask actually a lot, and I work with, last week I've worked a lot with it. The beauty of this mask is that it's got a single filter in front, and you can very easily cover that filter and the exhale valve that's there. I don't know if you can see my pointer there where the orange is, with a surgical mask. So you're protecting your exhale and you're protecting the filter at the same time, and it's quite a comfortable mask. And here you can see I'm working through the microscope. I also want to focus your attention at this stage. If you're currently using microscope magnification in your practice, look how far I am from the patient. And I'll talk a little bit about this plastic shield that we've developed for my microscope in a moment. And a very interesting conclusion that we can draw from that. So let's move up to the last level, ideal standards. This is if you really have no limitations on PPE, what can you do slightly better in your practice? And this is for non-aerosol. So here you can see you can use, instead of a surgical mask, even for examinations, you can use a N95 mask, or you can use one of your respirators. You have eye protection, head cap, disposable clothing that you will also, even with a non-aerosol procedure, also dispose, and foot covers. And then the ideal standards for aerosol generating procedures. Here you can see Misty again with a 3M face mask with the protected filters, eye protection. She's got one of those disposable gowns on and head cover. And if it's a COVID positive patient, you can probably go to the extreme to have a spacesuit on and put even a visor in front of your half face respirator. So, you know, you have to interpret these things of what the situation is, what you can afford, and what you think is the best protection for you and your staff in the practice. Sterilization staff and cleaning staff, I think this is the minimum. They can probably wear that gown for the entire day. A good level surgical mask. They're also exposed to, remember, they might be cleaning instruments and cleaning surfaces, but they're still exposed to the aerosol generating exposure in the complete practice. Maybe a patient coughed or something like that. So you can't just ignore that. And also head protection and very important shoe covers for them. And then your receptionist should be covered. If you look at the left-hand side slide, you can see there's a line there. That's a plastic shield that we put up. If you have that, they can probably get away by just using a good surgical mask and also protective clothing for the day. Or if you don't have a protective shield, I would suggest that you cover them with a visor that's sealed on top as well. So let me show you the last few video clips. There you can see I'm working without the protection plate, the Perspex plate. I'm using the thin space mask. I've got the protective glasses on. And here I'm using the protection plate that we cut that slides into my microscope. Now, interesting, so far, I've done quite a lot of aerosol generating procedures, and I didn't have one drop of splatter on my plate. And the key thing here is because I'm very far away from the patient and the plate as well. Our risk areas is when we work without magnification and our working distance is very close, so we work on the upper 7 maybe, and we look closely into the patient's mouth. That is the time that you're going to probably get contaminated. So in this stage, I would suggest that if you can adopt magnification or microscope magnification or loop magnification, you're putting yourself in a much safer level and further away from the patient, and your risk of them breathing, coughing, laughing, and creating a plume around you is a lot less. I promised you this is my last 2 slides. I'll excuse me. I'll end off just with comments on the vac station. The first one arrived in the country and I had the opportunity to test it. I'm not going to go in detail into it. You know, there's lots of filtrations, carbon filters, HEPA filters, the UV light. Just a point of interest, the brochure was wrong. It says here, particles bigger than 0.3. It's actually particles 0.3 and smaller that they filter if you look at the specifications. So here you can see it's in my practice where I'm working. In this case, I've got head cover on, I've got a surgical disposable gown on, I've got an N95 mask on, and I'm doing an aerosol generating procedure. And here we use the vac station. Now, in all fairness, what I found so far, I think if you use high volume suction and you use rubber dam, you probably reduce your aerosol by probably about 50% or 60% or 70% even, depending how good your suction is. So it's very difficult to video the amount of aerosol that goes into this machine. But when you put a very strong light on it, and maybe on the webinar video, you won't see it as clear, but I'm going to show you that. There's still a lot of aerosol that goes in there. So I think if you're currently not working with rubber dam, it's an excellent tool. If you're working with rubber dam, you're going to probably use it 50% of the time and 50% of the time not for procedures. So there you can see, I'm going to show you a close-up view now where I generated aerosol. And if you look very closely, and I'm not sure if you'll see it on the transmitted screen, you can see a plume of aerosol going into the unit there. So there's very little aerosol generated into your practice. And you can also see some splatter drops as it suctions that is condensated on the shield there. So with that, ladies and gentlemen, I want to thank you for your kind attention. I appreciate that you bared with me for this time. We were probably about 1 hour and 5 minutes. I hope that I've put the concept of wearing protective gear into good perspective for you, and we're looking forward with the panel to your questions. I will unshare my screen. And hopefully we can come back to the panel. I'll just have to wake them up. I think most of them are asleep now. Stephen, are you awake? Professor Moipolai, are you with us? Thank you. I'll hand over to Casey or to, I don't know who's going to handle the questions, if it's Noma.
Thank you very much, Prof, and thank you for everyone that has joined since my last introduction. I see we're sitting now at 535. I'm going to encourage members not to type any further questions, purely because we have already collected prior to this, as you would have received the link, close to 90, quite a lot of questions, yeah, about 90 something questions. So I'm going to go through these questions. I think it's best, there's quite a few good questions that have been asked on the collections earlier on. I'll just read the question. Some questions I believe now we have actually covered through the webinar. And if you are comfortable that you have covered, Prof, you can just say that is covered. We don't have to elaborate, but if you want to elaborate, you can say. As I indicated, I'm going to read it to the panel so that everyone hear the question, because we haven't shared this with the members. And then whoever wants to answer, please indicate by raising your hand, your physical hand, so I can see that you want to deal with that question or you want to add whatever the issue is, so we can move on. Let's go straight to the questions. Also have noted that in terms of Facebook, those who are in Facebook have since joined us on this platform. So thank you so much. It makes life easier. All right, first question. It says, I think this is more about Sada. So I had a complaint today from a community service dentist who is a Sada member of our branch, that they are being forced by their supervisor to do clinical work with no proper PPEs in place, no correct protocols as advised by the association. Please, whoever has given us this question, can you send me a direct email with the names of the people, the person you are referring to, and the clinic or the hospital where they are working at. It makes it easier. I've been, for instance, interacting with KZN, the provincial coordinator, very, very helpful on some of the issues that we have raised around this type of thing. So if I can get enough detail, I will know who to speak to. Second question is to the panelists. With large parts of the country not being in the hotspots and not having any confirmed cases in the area and working in small practices on medical aid rates with a patient base not financially able to pay balanced billing, what would the panel suggest we do in cases where we could have to close our surgeries due to a financial consideration and leave the community without dental care? Our patients, many of them on medical aid and receiving dental care at discounted rates due to our goodwill, are not at all able to pay a few hundred rands extra per appointment. Do we shut up shop? So it's not really a clinical question, but it's more a moral question as well. Dr. Swart?
Casey, I would like to respond to that question in what is happening in my direct environment, because I am in a hotspot. And two of the hospitals where I'm operating at, Panorama Mediclinic, which is one of the major hospitals in Cape Town, as well as the day hospital where I work, has been shut down for any elective work because of the high incidence of personnel that is tested positively. So in this time, I've also had two colleagues phoning me because of the natural testing that is done, or not natural testing, some of the testing that is done that is tested positively, and they were given up as contacts. And both of these, when they phoned me, I said, you know, did you follow our protocol? And they said, yes, because both was non-AGP procedures. So I said, don't worry, you are safe. Just monitor yourself. So the majority of what the protocol stood for is now found to be common knowledge. And I think if we have reached that point where everybody knows that, they don't know how they know it, but we set a protocol and they find that everybody is doing that and everybody knows how it works, then we are safer. And we must remember that South Africa, compared to the rest of the world, as Egon just stated earlier, shut down when they reached these phenomena that we are reaching. And we are going to contemplate taking it through this pandemic. And that is going to be a double-blinded sided study, as I jokingly mentioned the other night.
Thank you, Dr. Swart. I think part of the question, thank you for answering that, but part of the question, the person is asking here, because they're not able to pay for PPEs and stuff, they're not able to pay that extra to get the proper infection control equipment, and therefore the doctor or the dentist is not able to treat them because they cannot afford basically to subsidize. Is it morally okay to therefore close shop? I think that's also part B of the question.
Yeah, so that was sort of the introduction to that, because as long as you're not in a hotspot area, you can evaluate your own circumstances where you are. But both of these colleagues that phoned me frantically was very relieved when I said, you know, all you need to do is monitor yourself, because suddenly they realized there's different matters than the cost of the PPEs that's important in our jobs. Our families and the people that we go to is sometimes more important. And we must not be dictated by the medical aids on what we can do, but it's what is safe for us and our families that should come first.
Thank you. I'm going to ask some of the questions together. They may not necessarily refer to the same thing, but I think it's going to be easy if you deal with them that way. So I'm going to look at this question. Which are the highest recommended surface disinfectants from a safety perspective? And I would also like the panel to deal with, could we have more clarity on the efficacy of fogging and the use of HOCl? You want to take that one?
I think I'll take it, but I'm not going to answer it in full because I think we need to focus tonight on PPE and not on disinfectants. Hypochlorous acid is the talk worldwide at this stage. And today I received 2 different papers, and it's a pity Chris Marais just locked off because he could have commented on it. One of his friends wrote a paper in the UK about how good it is. And then there was a paper from China today that said hypochlorous fogging is not advised in a practice anymore. So we don't really know where to go with this product. In all fairness, if it works as well as people say, it will probably be the best disinfectant to use because it's safe to you, safe to your staff, safe to your patients. I had the privilege today to test an air purifier meter in my practice, and it was quite interesting. The best thing I found was that every time they clean my surgery, the chemical components in my practice the graph just goes high up, and that can't be good for our health. So I think let's stop there, and I think we must keep the questions to PPE and not to disinfectants because that was addressed before.
Thank you so much. The next question is, can shields be used without goggles, glasses, and is wiping of hands pieces acceptable? Anyone want to deal with that?
Okay.
Casey, can you just repeat the first part?
Okay, it says, can shields be used without goggles or glasses? And is wiping of hands pieces acceptable?
I would comment on the first part, and I think Peet is better educated to answer the second. The face shield is now accepted as a minimum standard at our hotspot. If you have seen a positive patient that was asymptomatic and you had a mask with a face shield on, you just monitored yourself, or you just need to monitor yourself. But if you saw the patient without a face shield, thus without glasses or a face shield, then you must quarantine for 14 days. So it can be used without glasses, but it's preferred that you use both.
Thank you very much. The next question is about disinfecting or disinfectants as well. It says, are Steritech disinfecting wipes efficient against COVID? And I know that Prof, you said let's focus more on the PPE. So maybe what we'll do on this is we've got them collected. Again, we'll just look at some answers at a later stage. The next question is, how do we stop sealed goggles and face shields fogging up, especially if we use both?
I have tried all of them because of the scuba side of it. And doesn't matter what you do, if it's completely sealed, it fogs. Even with the best defoggers that are available. So, and if you look at the goggles itself from Euwe and all the others, they have a system of ventilation away from the eyes, but it's always ventilated. So a sealed unit does not work in my hands at all. And I have gone and made little holes on the side where the strap goes and air ventilated that way, or using the smuggles where there's a more definite airflow.
Thank you so much. Does the dental assistant always need to dispose of all the PPE used during the procedure? If not, what exactly needs changing every time for the dental assistant? Must I repeat the question? Okay, Prof.
No, it's fine. I think I've got it. They asked this question that evening as well. I think it depends. Again, you have to assess your practice for the aerosol generating exposure, and also then for the aerosol generating procedure that you've done. I think if you're doing a low risk procedure, they probably don't have to change everything. But if it's a high-risk procedure, then you have to change. It's the same applies to the dentist. The same rule. They are probably slightly further away from the patient, so they probably at a slightly lower risk. But each situation will have to be assessed separately. There can't be a general rule to say that they can keep the clothes on or they can use 2 masks a day or whatever.
Thank you. In a webinar on dentistry recently, on a digital dentistry platform that is part of Sada and hosted by Dr. Mark Bowers, it was recommended to only use surgical masks for AGP procedures. Does the group of presenters present tonight agree with this, as it's very confusing for us as dentists when we see different protocols on the Sada document? Yeah, I would like someone maybe to deal with this, but maybe to preface this. I think for the person who's asked the question, remember Sada and the people that we have on this platform as we speak, what they advocate is what's on the protocol. And if a member or someone else hosts a discussion point, which maybe a different speaker speaks who is not part of or represent Sada, we must understand that that's how they see things. But we would still stand on what our protocol says. But I think I'm going to allow one of the two, I think one of the two that worked on or one of the 3 that worked on the protocol to maybe respond to that. Who want to respond to this? Dr. Swart?
I think it was eloquently dealt with in the lecture by Prof. Peet. He specifically stated that.
Thank you so much. I'm going to skip the wiping question. Now, maybe here, we need to speak about this because I've seen quite a lot of confusion on the use of hyperchlorous acid, hypochlorous acid, and hydroxy, I think it's hydroxide somewhere. I'll look at it. But here's the question: is hypochlorous acid acceptable to be used for disinfection for hand surfaces by wiping or spraying or fogging?
Okay, we're back at hypochlorous acid. It obviously features a lot. Firstly, let's just clarify the point that there's no hydrochlorous acid. That was a mistake in the document. So it's hypochlorous acid. And that will be corrected in a new printed version. It is a very effective way of disinfecting hands, surfaces, fogging, whatever. Although I've mentioned that fogging is a question mark at this stage. But it's probably one of the cheapest materials that you can use with the highest effect. I think if you look at the research, it's 100 times more effective than bleach, just to give you an example.
Thank you. The next question is with regards to someone saying that they've received an email saying the meeting was only starting at 8 o'clock and finishing at 21:30. I have checked all the communication, the invitation. I have checked the confirmation. It does not speak of 7 o'clock to 9 o'clock. So the member may have opened a wrong confirmation, but the times for this was absolutely correct on both the invitation and the confirmation. How long does the virus float in the air after an AGP? And I think, Prof, you have dealt with this very extensively.
Sorry, just repeat the question.
It says, how long does the virus float in the air after an AGP, aerosol generating procedure?
There's speculation from the studies I showed, it could be up to 3 hours.
Absolutely. I'm going to deal with this on a different platform with regards to 8110, but maybe what I can do now is to say to members, at one stage we suggested you use 9099 to claim for your PPE. We have found that certain schemes accept 9099 for you to claim PPE. Some schemes like Discovery have indicated to us that they don't use that code. We have given last week a directive that you must use 8109, which most other schemes will accept. With this, you may find that at the moment they are not accepting that particular claim. However, it looks like with the discussion that we're having, some of the medical schemes, the bigger medical schemes, would actually be able to even go backwards and pay you for what they would have rejected. But the directive says, please use 8109 or 9099, but please check with the scheme as to which one they would prefer. Next question, I think this is, I don't know if you guys will deal with this because Dr. Bowers is not here, but let me say it. Can Dr. Mark Bowers please comment on the difference between a sputum and saliva and the amount of coronavirus present in each? Is a single cough in a single, I suppose in a single cough, not much, is a single cough not much more if infective than a well-diluted aerosol of saliva, air, and water? Maybe we can deal with this question. Must I repeat that question? Can we please comment on the difference?
Okay.
Okay.
Lucky? Was I taking
I think it was well covered in the lecture of Peet.
Yeah, I think something that I can just mention, I don't know the exact answer to this question, but firstly, there is studies that show that coronavirus or SARS-CoV-2 is present in saliva. So we can't just ignore the fact that it's in saliva. I think the person that asked the question is correct. There's a higher viral load and maybe more infective virus in sputum when the patient coughs up. That's why the anesthetist is at a very high risk. And then I can see where the question goes is immediately it comes up that it's diluted in the dental aerosol. We don't know that. It's not proven, so we can't comment on that. We would love to see a study that it's not present in aerosol or very low and that it's not infective. That will make our life a lot easier. But I think I want to mention this again. Just remember that we're going into a phase of the plateau, not a plateau, of a high risk explosion of viruses in our country. And we have to protect ourselves until we pass that stage. So don't take chances and just ignore what we've been saying that this webinar.
Yeah, Prof, I think you mentioned a very important point. We are preaching to people that know the stats and know how infectious this virus is. Many people out there, they think, and I'm not talking about the dentists, I'm just talking about the public. They think that the relaxation of the current restrictions and the levels being relaxed looks like, we are no longer having a higher risk. But in actual fact, if you look at this, the way we are going, the way I see it, is like at the high level of alert, it meant how is the government and how are the health facilities ready to deal with the issues of the coronavirus and the knowledge that was available. At the beginning, there was very little readiness, and that's why we're at level 5. But in terms of the infection and the number of infections, it was very low. As we go down the route of level 3, level 2, level 1, it is more an indication of how ready we are to deal with the issues. But it does not mean the rate of infection is reducing. In actual fact, it's going up. And that's very important that we understand that and that even the public gets to understand that particular trajectory. It's not the other way around. We are not getting better, it's getting worse in terms of, and our risk is getting higher. But we are more ready now because we've got protocol, we have a better understanding, and hopefully we're gonna get ready. Prof.
Sorry to interrupt you, Casey. Can we maybe ask Egon to comment on these concepts of what is hearing outside in Italy, how dentists feel at this stage? Are they scared? What protection level are they wearing in their practices? Just for interest sake, because that's where the main epicenter in the world was actually.
Yeah, well, they first of all, my sincere compliments for what you put together as a protocol, and I think this is so important when the virus is at its peak. The practical problem in Italy is that the dentists were not able to get the materials. So you get a balance between personal protection and protection of the staff and the patients against the economical pressure on to get the whole system working again. So then what happens if a dentist does not get the right protection in-house? They start working in a way, and that goes on for a couple of weeks now in Italy, and the level of precaution goes down. because they look at numbers. The numbers did not pick up, because I agree with the president. After the lockdown, when dental offices start working again and people start socializing, the risk is higher. If everybody stays at home, the virus can be controlled. But now we have the situation in which clinics start working, they don't have the right tools, and then things are not controlled anymore. So yeah, the danger is that you get a second wave of infections, which can be worse than the first wave. In Italy, so far, it did not happen. And I'm talking about 2 to 3 weeks after the official opening of clinics. Clinics were never officially closed, but they were not advised to stay open. Since the 4th of May, it was allowed in some areas to start working again on patients. And we were ready for the worst numbers and that will take 2 weeks or so after the opening of dental offices. But so far, I think it did not happen. So also the virus can mutate. Transmission of the virus does not mean infection. So that's also a thing we have to take into account. So in one way or another, it seems they get away with a lower value of protection. But I think the whole committee, the whole panel did an excellent job. And of course, every area in the world has different dynamics and probably also a different type of virus. In Italy, they say, oh, the COVID virus is losing its power. So, and that's a very simple way of saying that probably the number and the environment is less dangerous. But that does not mean that in South Africa, where you are going towards the peak, I think you're doing an excellent job. So don't underestimate, that's my message. And if it goes well after opening up more and more clinics, it's a good thing. But we are in the highest group of risk. So I think you are doing an excellent job, really.
Thank you, Taco. Thank you. Are you aware that the PPE packs were not actually N95 mask, as they had said, and that all that was in my pack was 10 K95 masks and 1 visor? Now, we did actually in one of our communication indicate what would be in the pack. The one thing that I didn't really check was the N95, so that's information that I would check. Please take time to sorry, Prof?
We did address that, Casey.
Yeah. Please take the time to explain to us about respirators available from 3M, the one where you change the filters every 8 weeks. I think that will be for Rani.
Okay. Thank you. So what they're referring to is the half face piece respirators with the encapsulated particle filters. I do have to say that these are also under great demand right now due to the lack of N95s being available. So the half face masks or the full face from 3M would utilize the same encapsulated filters. And we do suggest you use encapsulated filters because these filters can be wiped down to be decontaminated. You also have to bear in mind that these half and full face respirators come in 3 different sizes. So prior to making a purchase, try and establish what size would best suit you and give you the best seal before you purchase.
Thank you so much, Rani. if your dental assistant is the one doing the sterilization, then does she need to doff the PPE before going to the sterilization room to place instruments in the autoclave or not? Please, can you explain the procedure she needs to follow to go to the sterilization room? Want to take this one?
Yes, I'll take that one. One can expect that in the surgery itself, that the aerosol might not only from a procedure, but the exposure as well, might be there at least until air changes occurred. And that's normally about 15 minutes. So for that 15 minutes, I recommend that my assistant keep her PPEs on. So her respirator is on for that time period. And once that is completed, we know that the taking off of the PPEs, the gowns and so, produces the highest risk. Therefore, between the sterilization room and just on the outside of the clinical room, we've put the bin for where we discard our PPEs before they go into the sterilization room.
Thank you. I think the next two questions go together. Regarding the reuse of masks that was discussed before about placing them into a brown paper bag for a week, can you let me know how many times can you recycle it in this way? And similarly, I know the reuse of masks is not recommended, but just wanted to know your advice on it. If we did recycle, how many times can it be recycled?
I know the answer. It is recommended by the CDC at the most 5 times, or as recommended by the manufacturer. And the reuse of masks in non-AGP procedures is a very good solution to economically work with that.
Thank you very much. The second question, the next question, I've already dealt with it. We are aware and referred to the recommendation by Sada, and we, as we said, we are hoping based on what the schemes are now saying to us that they may be able to actually ask you to resubmit the cost of PPE once they have finalized the fees, and that's what we can only hope for. The next question is, N95 masks are so expensive. Can we wear a surgical mask and visor over N95 mask so that we don't have to keep changing the N95 mask after each patient? I think, Prof, you kind of dealt with it, but do you want to comment?
Yeah, I think the more you protect the mask, especially in short times, firstly, a surgical mask covering it will protect it, depending on the amount of splatter you get. If you get a lot of splatter, then you will have probably to consider to change that N95 as well. And then secondly, if you put a visor over it, I think your protection level to the N95 is actually very high, and also to yourself. So I think that's a good idea, especially in this time. But you have to assess each situation as you go, because remember, now you've got a lot of things to dispose in your doffing stage. You've got a visor, you've got a surgical mask, and you've got the N95. So your chance of contaminating yourself is very high.
Sorry,
yeah, Dr. Swart?
Yeah, that recommendation has just, I think, in the last 3 days been changed by the CDC after some scientific papers came out. And the 3-ply mask over an N95 is actually proven to be detrimental. So that has been taken out and has been updated to only a facial shield over it. Yeah.
Thank you. Yeah, thank you. The next one is really a long comment, but the gist of it is, with this PPE protocol, are we not adding to the pollution? And then the member says, I've been doing dentistry since 1976, the first third of the time without mask or glove, just washing hands with Hibiscus scrub, after that gloves and mask. In all my years, I have not had 1 day off from infectious disease, and not once have I had a patient say that they think that they have picked up any disease from my practice. Are we not downplaying the human immune system a bit here?
I think Dr. Stephen Swanepoel is the oldest of us. He must answer.
Dr. Swanepoel?
I just say I think he's very lucky, and if he wants to play Russian roulette with us, it's on him.
Thank you so much. I think this was, as we're going through, I'm seeing no slides at all, Dr. Peet. To Dr. Cronje, the slides, the webinar is going to be available on our website. So if you did not see anything, please download it from our website and everything will be there. Thank you so much. Do you recommend that we use sleeve covers for hand pieces and scalers? Do you recommend that we use sleeves? Yeah, Prof?
I think the more protection you have, the better. I think one question we didn't answer before was, do you have to sterilize your handpieces or can you just wipe them? And I think this relates to that as well. I think it's not just wiping the surface. It's if you don't have anti-retraction valves in your handpieces, the virus can penetrate in there. It's shown in many studies that blood can actually also filter into the handpieces. So to answer that previous question, I think in this stage where we're going in a high virus load, you should actually autoclave those handpieces. And if you can afford protective sleeves, then I think it's a good plus point in your practice. It's not recommended in our protocol because we just looked at the essential stuff.
Thank you so much. The next question partly has been answered. What is happening with the promised payback from DPS and free PPE from PPS? Despite applying for both, I haven't received any. PPS is delivering. If you have applied, you will get it. Otherwise, please send an email questioning that. DP, we are still waiting for a final go in terms of when they are going to do the reimbursement, but we've had a meeting even yesterday, so that is also coming. The decision stays as it was. From Dr. Cronje, Doctor, please repeat the details of the half-face respirators of PNARS, which you suggest using as well as the filters. Thank you so much.
Ronnie, do you want to answer that? Because I don't know all the model numbers. I only know one.
No problem. Happy to do so. So on one of the first slides that you had a gray model. That is the 6000 series face piece. And it's also 3 different sizes. So if you order a size small, it's a 6100. If it's a size medium, it will be a 6200. And if it's a size large, it will be a 6300. Then later on, the one you actually used, the blue, that one is the 6500 series. So the difference between the two, the first one is made out of an elastomeric polymer, and the second one is actually a silicone product. So we find that you have less dermatitis issues when you use the 6500 range, because the silicone rubber is a lot more comfortable to wear and it handles body heat and oils a lot better. Whether you choose the 6000 series or the 6500 series, the filters that go onto it are exactly the same. So you don't have to have separate filters for the separate face pieces. On the filters, the recommended cartridges for particulate filters would be the 6035 or the 6038. Those are encapsulated particle filters that can be wiped down and decontaminated. Thank you.
Can you also, while we're there, can you maybe comment, because a lot of questions came up before on how to clean the respirator itself.
Okay, so when you're dealing with viruses, it's best to do a deep clean on your respirators. And the suggested protocol would be to soak your respirator in warm water with a soapy solution. And normal sunlight dishwashing liquid will suffice for that. You would then do a clean, and you could use a little nail brush to scrub it clean if you feel that it still has a lot of body oil on it. So you clean that first, and you should actually let it soak for at least 5 minutes in the solution. Remove it from there, give it a rinse in warm, clean water. You would then put it into a disinfectant solution, and you can use something as mild as Milton's or whatever disinfectant you are using in your practice, provided it does not damage the face piece. We can give you a list of what we would recommend, but you can use a mild detergent, a disinfectant like your Milton's. Soak that in there for at least 10 to 15 minutes. Take it out, rinse it again, and then let it air dry as far as possible. We try not to recommend wiping down the face piece, because if you use a cloth that lints, chances are pieces of the lint remain in the face piece, and when you don the respirator again, you might stand a chance of inhaling those little fibers. So as far as possible, you should air dry the unit.
A good idea might be to have 2 of these or 3 of these and change them around.
Correct. It will also give it enough time to dry so you don't end up creating mold within the respirator. But we do have documentation protocols on cleaning. So if anyone would like it, I can have it emailed to them. They just need to drop me their email addresses.
I think, Dr. Naidoo, it may be good if you can actually email it to Sada. We can publish it on our website to assist members. Okay.
Absolutely.
Prof. Peet, what is the device called that you use for aerosol extraction, and where can we get them?
At this stage, there's 2 devices available. The one I showed is from 80th Dental. They're available from Dental Warehouse. They've just got their first shipment in. And then I know that a company called Magnificent has also brought in. I haven't seen them yet in operation if they delivered yet, but that's at this stage the only ones that I know about.
Thank you very much. The question on CPD, if you are in the Zoom meeting, there's nothing that you need to do. You will get your CPD point. We will only validate your membership. I want to see your membership, the HPCSA numbers and everything, and what time you joined the meeting, but you will get it. There's nothing that you need to do. Thank you to Dr. Anonymous. May you please comment about the use of eldervase mask? It is a mask that kills the virus when it lands on the mask. Thank you. I don't know if anyone knows about this mask.
I've seen it. I think it's a cloth mask. I haven't seen any studies on it, but so I can't answer the question. But at this stage, I think it's important maybe to just ask Ronnie to comment on the electrostatic potential, how it's charged, the N95 masks, because I think a lot of people don't know about that. If you would allow me to direct that question to her.
Thank you.
Thank you. So yes, the 3M respirators do have an electrostatic charge on the filter media. And the most easiest way to explain this is if you have a pencil which you rub through your hair, and then you have little pieces of paper on the desk, you could actually lift those little pieces up from the electrostatic charge. So basically what it's doing is it's attracting the paper towards the pencil. So the same thing happens with the electrostatic charge on the filter media. As particles move towards the respirator, the charge captures it and holds it on the filter media. So it basically keeps the particle on the outside of the respirator, making it safer and easier for you to breathe through the respirator, so it's not causing any clogging issues.
Ronnie, how do you know if it's electrostatically charged? Do companies disclose that, or is it only 3M that's got that technology? Or because I've tried to look around, I can't figure out which ones are and which ones aren't. Is there a specification that you can see?
No, unfortunately not. It's not stipulated. It is part of the EN standard, but it's one of the protocols that you don't have to comply to. It is stated in the EN 149, but it's on the minimum spec where you don't have to actually have the static charge. So most companies would actually have it in their instructions for use. You will see it in there that they describe the filter media as being electrostatically charged. And other than reading that document, you won't really know.
Thank you.
And is that maintained after the cleaning, the disinfection procedure you just described?
Okay, so this is where we differ as 3M on that. We still don't recommend the disinfecting of the N95 respirators, as we haven't got conclusive studies to prove that the electrostatic charge actually doesn't dissipate. We do see degradation of the charge. So it depends on how many times it's been decontaminated, it could lose its charge. Hence, we follow the CDC and World Health Organization's guidelines, but as a 3M'er, we wouldn't really recommend decontamination.
Yeah, and I also heard that the virus can be deactivated by dry cleaning at temperatures of 70 degrees for half an hour or more. Can you comment on that method, maybe?
Okay, so here again, we also have done our own studies. And what we did find is that it does melt the fiber at some degree. So there's also that you have to take into consideration. So most of the companies that are recommending the decontamination haven't looked at the 4 protocols, being the electrostatic charge and of course what the heat does to the actual fiber. All they've done the tests on is how much viral content was on the unit initially and how much was on it after the decontamination. Yes.
Exactly. Thank you.
Yeah, so they usually don't look at the fit of the mask. And when a study look at the fit of the mask, they don't look at the bacteria or viral concentration again. There's very few studies out to show both those aspects. So it's a very good point.
Okay.
Correct.
Thank you very much. The next 2 questions go together from Dr. Groene and I think Dr. Combrick. What do we ask patient to do with his or her mask when he removes it from his face? Some patients drop it below their chins, while others throw it onto your work areas. And similarly, what is the protocol for patient safety when using a surgical respirator?
I'll take that one. We try to shorten the time that the patient is without a mask to as little time as possible. So even until the patient reclines and just before a cover is poked over his body, we ask him to take off his mask and put it in his pocket. And immediately when we are done, he must re-don the mask again.
Thank you very much. I'm worried about time. We're now at 9:10. I think maybe let's take 10 more minutes, and then the rest I'm going to ask the panel to actually respond in writing to the rest of the questions, and we're going to try and circulate to all the members that have attended and make it available on the website anyway for those who did not attend. Because I want to make sure that we've covered some of the things that we may want to cover that we have not said yet. So let me take a few questions and then we can conclude. Not quite sure what this question refers to. What kind of UV light is that in the toilet? There are so many options. Does anyone? I don't remember this particular comment.
I'll comment on it because it was my slide. The light is from a company called the Cleaning Medic, that you can that you actually rental the UV light to disinfect surfaces in your practice. But I've asked him to modify the clamps for me and install it permanently. So you can buy them as well, but this is quite a good option. You pay about 300 Rand a month to rent one of these lights.
Thank you so much. Prof, practitioners who have a 1-room plus reception setting, how do you suggest they take off their contaminated PPE because they don't have another room to do so?
Yeah, that's a difficult question. I think what I would suggest is to take off your PPE in the surgery after the patient has left and then disinfect the entire surgery. That would be my solution if there's no other area. I don't know if Blackie wants to comment on that as well.
We have we've got a deep cleaning in the toilets in the public toilets in our passage, and we would if we come to the office, we would just take the daily new clothes that's sterilized and then don it in the toilet and then come back, and that is then put through to the building so that they deep clean that areas. So we try to not contaminate a certain area because there's more than one area where we then each don our clothes.
Thank you, Dr. Mayet. Thank you so much for saying excellent presentation, Prof. I just want to clarify, this is to me, I suppose. I just want to clarify, should we stop using 809 and 8110 and put all under 9099? No. If you read the Sada that we released last week, I think it might have been Thursday or Friday. It's available on our website. We are recommending that you choose between 8109 and 9099. But please check with the scheme which one they would prefer. 8109, mostly because it is already there and most of the schemes have made some provision to it. So we've got a feeling that most schemes are gonna, including Discovery, are gonna be more amenable when you use 8109. But we also have spoken to other schemes that are happy with 9099. I think Best Med is one of them. So just have a chat with the scheme before you charge, and you choose 8109 or 9099. Will the use of hydrochlorous acid as a fogger in the surgery during aerosol generating procedure be effective to kill the virus in the air? HOCl has been found to be 99.9% effective. Please, can we kill this clearly, like Prof?
I don't know how to kill it because we've discussed the fact that there's controversy about fogging with hypochlorous acid. Let's kill that now. There is no hydrochlorous acid. You can't even Google it. There's only hydrochloric acid, not hydrochlorous acid. So yes, it's a good disinfectant. We're not sure about the fogging.
Thank you so much. I think this one has been dealt with. Please give me more information on extended wear of N95. The respirator stays in the place for several. We've dealt with this one. I'm going to pass it. Good evening. With regards to half mask filters like the P3 2083 pancake types, can they be treated with UV light to sterilize or disinfect or ultrasonic? Rani, do you want to deal with this? Sorry, you are muted. You are still muted.
Sorry
Thank
about
you.
that. Okay. Again, here we would follow the World Health Organization's guidelines in terms of decontamination. Those filters, the issue we have with that is there is transferal that could happen because it is an open filter. So in order to remove it to wash your face piece, for instance, you would have to touch the actual filter to remove it and get it off, decontaminate. But yes, to answer the question, you could use the protocols as described or any of the others as suggested by the World Health Organization. But again, I'm going to allude to the same effect of decontamination with regards to N95s, where there could be degradation of the fibers itself. Okay.
Thank you very much, Rani. I see a well-known name here, Dr. Greg Boyce Valley. Me and him went to school together those years. So I'm glad to see you, Doc. He says most operating theaters use Halyard surgical mask and shield masks and N95 respirators. Why, when you phone these companies to order mask respirators for your practice, they won't sell them to you because you aren't a hospital? Does 3M have the same policy or similar policy? And are we able to order straight from 3M for our practices as in individual practices? Rani, I think this is more for you.
I'll take that, yes. So 3M's business model is to sell to approved distributors who would then supply to the market. It's because we do such a wide variety of products that we cannot do individual sales. We just do not have the capacity to do it. 3M on its own does about 60,000 different products. So we cannot manage small orders. So I would suggest, again, I can submit a list of all the approved distributors and you are more than welcome to make contact with them. They will sell you 1 box or 5 boxes, just dependent on what you require.
Okay, thank you. Dr. Makwakwa, thank you for the presentation. Please advise on the PPE required when taking intraoral radiographs.
I think you have to follow AGP procedure because the patient can very often cough. And that
Thank you.
brings up highly infectious sputum.
All right. Is dental extraction classified under age? Anyone know this one?
And the AGE. Lucky, you can comment that.
As long what we recommended in the protocol is if you're in an environment where it's socioeconomic difficult, in a difficult situation, whether people say they're poor, the medical aid rates doesn't even cover that, then do the extractions, but stay away from rotating instruments. Rather go to the older methods of using perotomes and elevators rather than rotating instruments. Then it is a non-AGP procedure and it can well be done with minimal PPE.
Can we deal with these two questions together? Can I cut a hole in a visor for loops? And did Dr. Blakey say that you can wear a visor over your mask so that you can use it for long? I think this way, the answer is yes. Does that mean one N95 respirator covered by a visor? But I think let's deal with the issue of cutting a hole in the visor. Can you cut a hole in the visor for loops?
I've seen that done very delicately by Dr. John Bronner. He's a technically very, very sound, and he had it laser cut according to his own loops. And then it was a very tight fit around the loops itself. But if you are going to do it with the scissors, there might be a problem, because it's a direct air link where droplets can actually go through.
Thank you. The next question, Prof, the visor that you are wearing over your loops, what is that? What visor is that?
There's quite a lot of these visors available. Blackie can maybe comment on where you bought these. Mine is from similar to the one you can buy from Take-A-Lot. But you have to be careful, and I've just grabbed a new one that's very similar. So as you know, I recommended one with a hood here, but this specific visor I bought from Pinar and Bros. But the distance from where my face would be and the visor is very short. So when I put this visor on, it looks very similar to my one, the blue one. When I put this visor on, I can't close it. So you have to make sure there's quite a bit of distance between your eyes and your loops and where the visor shield is. So I can't give you an exact name, but you must make sure that there's enough distance.
Has any of you heard of the virustatic shield from Milner's, and can this be used as part of PPE?
We had that question before.
This one is it's a set comment, but it's where we apparently, someone feels that we are giving the platform mainly to contracted out dentists. I want to say that the team that you see here today is not the complete team. The complete team included all kind of dentists in the academic field, in the rural areas, contracted in and contracted out dentists. So the fact that you see the people here advocating for the protocol does not mean they were the only ones that actually contributed towards the protocol. It was well represented. So it's not accurate what is being said there. I'm going to take just one question, and then I'm going to close this. We've answered about 40 questions now out of 49. So there's 9 questions, which I believe we can deal with it separately. Hypochlorous acid has been mentioned to be very safe and natural occurring. However, when it dissociates, isn't the chlorine component very dangerous for inhalation? Was wondering, as there are lots of disinfectants which contains hypochlorous acid as well as fogging material. Prof, I see you shaking your head.
Now we're back at this again. Let me just read the question again. Hypochlorous acid.
Oh, sorry.
Okay.
Sorry.
It's as far as I can remember the question, it's not combined with other chemicals as far as I know. And the studies that is or reports on fogging, it's not dangerous at all. It's probably the only product that you can drink, that you can put in your eyes, and it's used extensively in wound healing.
Thank you so much. To the members that are attending this webinar and to the panelists, I think we have to stop here, otherwise we won't be able to finish. We're going to collect these questions, and I'm going to ask the panelists to answer the questions in writing, and then we're going to make this available on our website. Where possible, we will email this to the members. I just want to maybe go through the panelists and see if there's any additional thing you want to make in closing, starting from Dr. Swart.
I just want to say it's a recommendation document, it's guidelines, and there's only two essential parts. The one is to stop the spread of the virus, and the other is to protect the operator and his staff.
Thank you. Dr. Pata, anything you want to add?
Yeah, thank you, Casey. Just maybe that, as Dr. Swart said, these are recommendations, and yes, we don't recommend reusing masks and reusing visors, etc. But when you are in a clinical situation and you cannot get hold of masks and you cannot get hold of extra visors, clean what you've got, reuse what we've got, because even recycling them is better than not using any protection at all. It's not ideal, it's not the golden standard, but you've got to do what you can to protect yourself and protect your staff and protect your patients. Thank you.
Dr. Swanepoel?
Thank you, Casey. No, there's nothing that I want to add except to say stay safe and look after yourself.
Rani?
Just one comment. People using N95s, there is a process to donning it as well, and you should actually do a fit test before you use any respiratory product to ensure that you are wearing the right size product or that the product actually works for your face shape.
Prof. Moipolai?
Thanks, Casey. I want to reiterate what the other panelists.
Prof, we've lost you. All right, while I wait for Prof, okay, we had lost you for a bit. Please start again.
Oh, no, I think I'm in total agreement with the other panelists. And I think what is really critical is that it's really incumbent upon us to keep educating ourselves so that we stay current with what is going on, because the situation is very fluid and there's a lot of uncertainty. And we need to keep informing ourselves. And kudos to Sada for keeping the information sessions going. Thank you.
Yeah, Dr. Egon, I'm sure you've got some stuff to add and as last words to the South African oral health care.
Yeah, I think extremely good recommendations, but they are time dependent and dependent on the area where they are imposed to. So I agree with the previous professor that we have to update this information almost weekly, because in a month's time, it can be different. I think we all agree on that.
Yeah, thank you very much. Thank you so much. And Prof, as the last word.
I just want to say, firstly, thank you for this opportunity to share these ideas tonight with the group of dentists that's listening. I think it's excellent that we're now on 2 hours and 44 minutes and we still got 464 participants on my screen. And I want to thank my fellow panelists for keeping us going and sharing knowledge, and also for the protocol group that we're still in the background working very hard, getting the knowledge out to you. And I think what Egon said is very important, that these things change. We might have a webinar in a month's time to show that dental aerosol is not infectious, but at this stage we don't know. So please keep safe and enjoy dentistry still. I know it's very difficult, but just keep your head up and keep on going, and hopefully we'll get all to a positive side towards the end of the year. Thank you very much for the opportunity, and thank you for you, Casey, for driving this venture an education platform on Sada. We really appreciate it as practitioners. Thank you.
Thank you. As we come to close, maybe aligned to what Egon has indicated and what Prof has just indicated, you will see that when we release the design document on the protocol next week, there will be, hopefully next week, there will be some changes, because since we released the first document or the draft document, there's been other learnings that the group has and other research and other information that has come across. So that document in itself has changed already. We don't expect that that will remain as it is. As we get more knowledge, as we get more research into fields that relate to COVID-19, that document will keep on being updated. So when you get the document next week, please do not think that it's exactly the same as it was when we released it as a draft document. I want to thank all the members that have joined us. I want to thank all the panelists. We are learning, and let's keep on learning. As we get information, let's keep on learning. Let's research. For those that are attending from this webinar tonight, as you ask these questions, this is valuable to the panelists. This is valuable to Sada. This is valuable to the profession, because every time we get a question, it makes us think, what is it that we have not covered that is actually important in terms of infection control, particularly during this COVID-19. So we appreciate your questions. Keep them coming, and please attend these webinars to learn and ask the questions. We will get some time at some stage where we are going to ask our members or the members of the profession to actually share their experiences themselves on what is happening practically in their practices, so we can also learn. But I want to say thank you very much and have a lovely good night to everyone. Thank you.
Bye-bye.
Bye-bye.
Bye.
Thank you, Casey.
Thank you, thank you, thank you.
I'm ending.
Bye-bye, 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 bye-bye. Dr. Egon is still there.